So imagine walking into a doctor's office, right? You finally gather the courage to bring up this very specific, deeply personal concern.
Which is already so hard to do.
Exactly. It's been quietly causing you distress for months, maybe even years. You sit on the exam table, you take a deep breath, and you say, I feel a loss of sensation down there. It feels loose.
Right. And you expect them to look at that specific issue.
Right. But your doctor, instead of examining that specific area or even talking about vaginal health right away, they just look at you and say, well, let's talk about how often you pee.
Which honestly sounds like a complete non sequitur. For anyone sitting in that room, it probably feels like the provider just isn't listening at all.
Or maybe like they're deflecting from a taboo subject.
Yeah,
right?
exactly.
You'd probably think you walked into the wrong clinic entirely. But here is the fascinating central mystery that we are unpacking in today's deep dive. If someone is experiencing a distressing feeling of vaginal looseness, medical experts actually insist that the very first thing we should investigate is their bladder.
It's so counterintuitive, but investigating urinary symptoms is actually the ultimate diagnostic secret to unlocking the right treatment for vaginal laxity.
Which is just wild to me.
Oh, it fundamentally changes how we understand the entire architecture of pelvic health.
It really does. So we are jumping straight into the incredibly complex, often misunderstood, and let's be honest, heavily marketed world of vaginal laxity.
Oh, marketing is everywhere.
It is. So to do this, we're looking at a huge stack of rigorous medical sources. We have scoping reviews on laxity measurement. There's the Developist study on sexual function, FDA safety communications, and UK guidelines from both NICE and the British Menopause Society.
It's a really solid foundation of evidence.
Yeah. So our mission today is to cut through the taboo, cut through that slick marketing, and figure out why asking about the bladder is basically the key to treating the vagina.
And I think this is a crucial conversation for anyone listening, really, because vaginal laxity is just spectacularly underreported.
How underreported are we talking?
Well, the sources indicate that up to 80% of women experiencing it do not bring it up to their primary care doctors.
Wait, 80%? That is a massive majority.
Yeah, it's huge. And the silence is largely driven by embarrassment or, this widespread mistaken belief that losing sensation is simply a mandatory penalty of aging or childbirth. Like, you just have to live with it.
Right, like it's just part of the deal.
Exactly. Yet, when we look at data from plastic surgery centers where people are specifically seeking aesthetic interventions, 1 in 6 women report vaginal laxity as a primary concern.
Wow. Okay, so the disconnect between what women are actually feeling and what they're discussing with their regular doctors is just massive.
It really is.
Well, let's establish exactly what we're talking about when we use the term vaginal laxity, because the International Urogynecological Association and the International Continence Society, they have a very specific definition.
Right. They define it as a subjective complaint of excessive looseness.
Subjective?
Yes, the word subjective carries an enormous amount of weight in that medical definition. Vaginal laxity is fundamentally a sensation.
Okay, so it's a feeling.
Right. It's a feeling reported by the patient, which often leads to decreased sexual satisfaction, significantly reduced friction during intimacy, and, frankly, a profound amount of emotional distress and impact on body image.
Right. And I think we have to contrast that subjective sensation with something that sounds incredibly similar but is medically entirely different, which is pelvic organ prolapse, or POP.
Yes, very important distinction.
Okay, so to visualize the difference, I was thinking we could look at the pelvic floor essentially as a trampoline.
Okay, I like this.
So vaginal laxity is like the mat itself losing its bounce and tension over time. The fabric just doesn't snap back the way it used to. Whereas prolapse is when the actual metal springs break and the whole frame visibly sags downward.
Yes, that visual captures the mechanical difference perfectly. Prolapse is structural.
It's physical.
Exactly. It's the physical, measurable descent of pelvic organs. So like the bladder dropping down to form a cystosol, or the uterus or rectum dropping, and basically bulging into the vaginal canal.
So a doctor can actually see that.
Oh, absolutely. Providers can literally take out a ruler and measure that descent using a standardized physical exam called a POPQ.
Okay.
But laxity, the loss of bounce in the mat, to use your analogy that doesn't have a ruler.
Right. Because it's a feeling.
Go ahead.
And looking at the Developist study in our sources, which, by the way, stands for Description of Vaginal Laxity and Prolapse and Correlation with Sexual Function, the data on this exact distinction is incredibly revealing.
It's a fascinating study.
Yeah, it was a rigorous multi-center study.
Yeah.
And they took this dual approach. First, they used a tool called the Vaginal Laxity Questionnaire, the VLQ, to quantify the patient's subjective feeling of looseness and the distress it caused.
Right.
And then they performed those detailed POPQ physical exams you just mentioned to measure for structural prolapse.
And the findings really upend a lot of assumptions. Because a patient's subjective feeling of laxity on that questionnaire does not correlate with the physical exam findings of prolapse.
Wait, really? So a woman can feel incredibly loose, bringing her immense distress, but structurally, a doctor will look at her and say everything is exactly where it should be.
Exactly. That happens all the time in clinical practice. You can have a very high sensation of laxity with absolutely zero measurable prolapse.
Wow.
And conversely, you can have a patient with a significant measurable prolapse who reports no sensation of laxity whatsoever.
That's wild.
It is. But the Developus study basically proves that laxity is a distinct sensory alteration.
Yeah.
It's a change in tissue integrity or nerve function, not necessarily a visible anatomical failure.
Okay, so if a woman goes to her doctor and is told, her anatomy looks perfectly normal, but she feels this profound loss of sensation, we really need to know what is actually causing that feeling. Which brings us right back to our weird doctor's office scenario from the beginning.
Right, the P question.
Yeah. Why do laxity and urinary issues so frequently show up to the party together?
Well, simply put, they live in the exact same biological neighborhood. They rely on the exact same structural foundation.
Makes sense.
The pelvic floor is this highly interconnected, continuous web of muscle, fascia, and nerve pathways. So trauma to the levator muscle during a vaginal childbirth, especially if there was, say, a prolonged pushing phase or an episiotomy that can damage the support structures for the vagina.
Right.
But it simultaneously damages the support structures for the bladder and the urethra.
So childbirth trauma is obviously a well-known factor, but the scoping reviews in our stack point just as heavily to menopause as a primary culprit, right?
Yes, and this introduces a critical piece of the puzzle, genitourinary syndrome of menopause, or GSM for short.
Okay, TSM.
When estrogen levels plummet during perimenopause and menopause, the urogenital tissue undergoes a fundamental transformation.
And the biology here is where the story gets really intricate. Because,
Right.
if a patient feels a physical looseness in their vagina, it just seems so counterintuitive to start analyzing their urinary tract. On a plumbing level, they're two completely different pipes, right?
Well, they are different pipes, but they are constructed from the exact same materials. And they depend on the exact same hormonal fuel to function.
Okay, so estrogen is the fuel.
Exactly. When estrogen drops, the vaginal mucosa, the lining, becomes pale and extremely thin. And as it thins out, the superficial cells of that lining stop shedding the way they normally do.
Right, and that shedding is important.
Highly important. That lack of cellular shedding results in a massive reduction of glycogen in the vaginal environment.
And just to clarify for everyone, glycogen being the primary food source for the beneficial bacteria in the microbiome, right?
Precisely. So without that glycogen to feed on, the healthy lactobacilli bacteria basically starve and die off.
Oh, wow.
And as the lactobacilli disappear, the vaginal pH rises. It shifts from a healthy acidic state to a much more alkaline state.
And alkaline is bad news here.
Yes, because that alkaline environment is just a breeding ground for bad bacteria to overgrow.
Okay, so the surface environment is entirely disrupted. But what is happening underneath all that, like in the structural layers of the tissue?
Beneath the surface, the lack of estrogen basically forces the fibroblasts to go dormant.
And fibroblasts are.
They're the cells responsible for producing collagen. So with them dormant, the existing collagen fibers begin to fuse together into these dense, unyielding bundles. And on top of that, the flexible elastin fibers actually splinter and fragment.
Oh, wow. So the tissue is literally losing its stretch, its elasticity, and its bounce all at once.
Yeah.
The mat on the trampoline is fully degrading.
It is degrading rapidly. And here's the kicker, because the lower urinary tract, specifically the bladder lining and the urethra, relies on that exact same estrogen to stay thick, elastic, and healthy. The systemic estrogen drop hits the bladder just as hard as the vagina.
Oh, I see.
So genitourinary syndrome of menopause, GSM, causes both the physical sensation of vaginal laxity, AD, a cascade of urinary symptoms, things like sudden urgency, frequent urination, and recurrent urinary tract infections, largely due to that altered microbiome we talked about.
So you simply cannot separate the two.
Yeah.
They are two distinct symptoms stemming from the exact same root cause, which is tissue starvation.
Exactly.
Okay, well, understanding that shared ecosystem makes perfect sense. But looking at the broader landscape of women's health today, It seems like the aesthetic and cosmetic industries have entirely bypassed this interconnected web,
Oh, completely.
because our sources dedicate a lot of ink to the explosion of non-surgical vaginal rejuvenation treatments.
Yes, the market has absolutely been flooded with energy-based devices, or EBDs. These include fractional CO2 lasers, erbium YAG lasers, various radiofrequency devices,
Right.
and they are aggressively marketed directly to women as this high-tech panacea for everything from laxity to dryness to mild urinary leaks.
So the underlying mechanism of these devices is fascinating to me. How are they supposedly restoring that lost bounce to the trampoline?
Well, the entire theory rests on the concept of thermal injury. These devices are inserted, and they're used to heat the vaginal connective tissue to roughly 40 to 42 degrees Celsius.
But 40 to 42 degrees, that is significantly higher than normal body temperature.
It is. It's hot enough to induce localized tissue edema, which is immediate swelling, and to create a controlled thermal burn in the microscopic layers of the tissue.
A burn.
Yeah. The hypothesis is that this intentional injury shocks those dormant fibroblasts we mentioned earlier. By injuring the tissue, the body's emergency repair mechanisms kick in, theoretically tricking the cells into producing brand new collagen and elastin, which supposedly tightens the vaginal canal.
Okay, I have to push back on this from a logic standpoint. Because if lasers successfully build collagen to tighten the skin on our faces, and I mean, dermatologists have been using them safely for decades to erase wrinkles, applying that exact same technology to vaginal laxity seems like a massive high-tech win. It sounds entirely logical.
I mean, it sounds so logical that the marketing essentially writes itself.
Right.
But the problem is that vaginal mucosa is not facial skin. It is an entirely different type of mucosal tissue with completely different moisture requirements and friction dynamics.
Oh, that makes sense.
And the reality check from the medical community regarding these devices is incredibly severe. The FDA actually issued a strong, unambiguous safety communication warning specifically against using these energy-based devices for what they call vaginal rejuvenation.
Wow.
A federal agency issuing a direct warning against a popular cosmetic procedure is a huge red flag. And the pushback is global. The UK's National Institute for Health and Care Excellence, the NICE guidelines, they explicitly state that these energy-based devices should not be used routinely for laxity or vaginal atrophy outside of strictly monitored clinical trials.
And the International Continence Society agreed, right?
Yes, they reviewed the data and arrived at the exact same conclusion.
Okay, so the scientific community is heavily slamming the brakes. What are they seeing in the data that the marketing brochures are obviously leaving out?
Well, primarily, they're seeing that the marketing is vastly outpacing the actual science. The scoping reviews in our stack point out that the studies supporting these lasers are mostly short-term. They frequently lack any placebo or control groups. And surprise, surprise, they are overwhelmingly sponsored by the very industries manufacturing the devices.
Of course.
We simply do not have robust long-term safety data.
But wait, don't the clinics show biopsies proving that new collagen is forming after the laser treatments? I feel like I've seen that.
They do show biopsies with increased tissue density, yes. However, many pathologists and independent experts argue that we might not be looking at true, healthy tissue regeneration.
What are we looking at then?
We might simply be looking at reparative scar tissue forming in response to a thermal burn.
Oh, wow. Scar tissue.
Yeah, scar tissue is denser, yes, but it is not elastic, and it is certainly not functionally healthy mucosa. We just do not know the long-term complication profile of repeatedly burning this incredibly sensitive tissue over 5 or 10 years.
That is terrifying. So women are paying thousands of dollars out of pocket for these aggressively marketed laser treatments, hoping to restore the natural elasticity of their bodies, and they might just be laying down rigid scar tissue instead.
The potential for harm is very real. And what is even more concerning from a clinical perspective is that by jumping straight to a lucrative laser treatment for a subjective feeling of laxity, both the patients and the providers are entirely skipping the most crucial diagnostic step.
Right. Which brings us back to the central mystery of this whole deep dive. Should urinary symptoms be investigated before treating vaginal laxity?
The resounding, unanimous answer from every single medical guideline in our stack of sources is yes.
Yes.
Investigating the bladder acts as the ultimate diagnostic compass. It prevents providers from over-treating a patient with risky, unproven lasers, and crucially, it prevents them from under-treating hidden medical conditions that are the actual source of the discomfort.
Okay, let's break down exactly how checking the bladder solves the laxity mystery, looking at 3 specific scenarios from the sources. Because the first one is shockingly simple, right?
Yeah.
A basic urinalysis.
It is the most basic test in medicine, but changes everything.
Walk us through it.
So imagine a woman presenting with vague vaginal discomfort, a distressing feeling of laxity, and she casually mentions, oh, I've started leaking a bit of urine when I run. A purely cosmetically focused provider might see a weak pelvic floor and immediately recommend a Titan laser package. But if a thorough physician does a simple urine dipstick first, they might discover a low-grade urinary tract infection.
Wait, really? A UTI can do that?
Yes, a UTI can completely mimic the symptoms of an overactive bladder. The infection irritates the sensitive lining of the bladder, causing spasms, sudden urgency, and unpredictable leakage.
Wow.
By prescribing a short course of antibiotics to cure that simple infection, the incontinence might vanish entirely. The patient's pelvic health is restored without a single expensive laser going anywhere near her tissue.
That is incredible. The entire clinical picture shifts just by checking the urine.
Okay.
Okay, well, the second scenario from our research is highly counterintuitive because sometimes the core problem isn't that the pelvic floor is too loose. It's actually that the pelvic floor is too tight.
Yes, we are talking about hypertonic pelvic floor muscles.
Hypertonic.
Right. The muscles are constantly overworking, locked in a state of spasm, and utterly exhausted. When a muscle is constantly clenched like that, it has no remaining range of motion. So when the patient sneezes or coughs, the muscle cannot contract any further to stop the flow of urine, which leads to leakage.
Okay, we have to unpack the mechanism here because how does a muscle being too tight make a woman feel like she's too loose? That seems entirely backward.
It does, but it has to do with proprioception.
Which is?
It's the brain's ability to sense where the body is in space. Think about clenching your fist as hard as you can for an hour.
Okay.
Eventually, your hand goes numb.
Yeah.
Right? You lose the sensation of your fingers.
Yeah.
The same thing happens in the pelvic floor. When those muscles are clenched 24/7, they fatigue and essentially go numb. The nerve signals degrade. And the brain registers that profound lack of sensation and numbness as a feeling of emptiness or looseness.
Oh my goodness, the brain is literally misinterpreting exhaustion and numbness as a lack of physical tissue. So imagine taking a patient whose muscles are already in a state of exhausted, hypertight spasm and firing a thermal laser at them to intentionally tighten them further.
It would be a catastrophic clinical error. The heat and trauma could drastically worsen their muscle spasms, amplify their pelvic pain, and exacerbate the urinary leakage.
So what do they actually need?
What a patient with hypertonic muscles actually requires is a referral to a specialized pelvic floor physiotherapist. They need targeted therapy to learn how to actively relax, downtrain, and release those spasming muscles.
And you only find that out by checking the bladder.
Exactly. You only discovered that underlying hypertonicity by thoroughly investigating the urinary leakage and performing a proper hands-on physical exam.
Man. It is essentially like trying to fix a drafty window by immediately ripping it out and installing incredibly expensive high-tech new glass. But what you really needed to do is go down to the basement and check if the foundation of the house was shifting.
That's a great way to put it.
Right, because if you fix the shifting foundation, the urinary and muscular health, the window might just align itself perfectly.
And the UK guidelines champion that exact approach. You must address the foundation first. Which brings us to the third scenario.
Okay, let's hear it.
If the bladder investigation reveals that the root cause of the urgency and the laxity is genitourinary syndrome of menopause GSM, the foundation is crumbling due to a lack of hormones.
And the treatment for a hormone deficiency isn't a laser burn. It is hormone replacement.
Exactly. The gold standard, first-line treatment recommended by the guidelines is local vaginal estrogen. By prescribing an estradiol pessary or an estriol cream inserted directly into the vagina, the provider is delivering the exact cellular fuel the tissue is starving for.
And that's safe for most women.
Highly safe. The guidelines emphasize that local estrogen has incredibly minimal systemic absorption, making it safe for the vast majority of women, even those who maybe cannot take oral hormone replacement therapy.
So when you introduce that estrogen back into the foundation, the whole biological cascade we discussed earlier basically goes into reverse.
It does. The tissue begins to thicken, the cells start shedding properly again, which returns glycogen to the environment.
And then the good bacteria come back.
Right. The healthy lactobacilli bacteria feed on the glycogen and thrive, dropping the pH back to its protective acidic state. The fibroblasts wake up and naturally begin supporting collagen again.
That's amazing.
And the urinary urgency and recurrent infections halt because the bladder lining is restored. And very frequently, as the tissue regains its natural plumpness, hydration, and elasticity, that distressing subjective sensation of vaginal laxity is relieved simultaneously.
You fix the drafty window by restoring the integrity of the foundation.
Yeah.
The science is just incredibly clear when it's laid out logically like this. But it exposes a massive disconnect in how information reaches patients. I mean, if the most advanced medical guidelines universally demand that we start with conservative care, like investigating the bladder, utilizing pelvic floor physiotherapy, and applying local estrogen, why is the dominant message women hear focused almost entirely on expensive, non-surgical rejuvenation lasers?
It's a tough question, but it forces us to confront how women's health and aging are commodified. Vaginal laxity is not a trivial complaint, It is deeply distressing. It impacts sexual function, self-esteem, intimate relationships, and overall quality of life.
Absolutely.
When women are desperate for a solution and the traditional medical system dismisses their concerns by saying, oh, it's just a normal part of getting older,
Which happens way too often.
way too often, they are driven straight into the arms of the aesthetic industry. And the aesthetic industry is masterfully equipped to sell quick, high-tech, expensive fixes.
Right. But treating laxity as an isolated cosmetic issue completely ignores the structural reality of the human body. It ignores the bladder, the musculature, the nerve pathways, and the hormones.
And this is why the medical sources in our review are so adamant. You must investigate the urinary symptoms first. Whether that investigation uncovers a simple, easily curable infection, a hypertonic muscle desperately needing physical therapy, or a hormonal starvation requiring local estrogen. The bladder inevitably tells the true story of what the vagina is feeling.
Wow. What we've uncovered today is that while vaginal laxity is a highly valid, distressing sensation, it does not exist in a vacuum. It is one thread in an intricate, interconnected pelvic web.
Definitely. And by insisting on investigating those urinary symptoms first, patients and their doctors can avoid the expensive trap of unproven quick fixes. They can uncover the true root causes, whether that's menopause, muscle dysfunction, or simple infections leading to safe, evidence-based, and truly lasting relief.
It really reframes the entire approach to bodily care. It's not about cosmetically tightening a loose thread. It's about restoring the fundamental health of the entire fabric. We have seen how deeply interconnected our pelvic health really is, and how easily a cry for help from the bladder can manifest as a loss of sensation in the vagina.
It's a huge paradigm shift.
It really leaves us with a final thought for you to mull over today. If the medical establishment and the aesthetic industry focused as much on holistic, foundational pelvic health, hormone education, and easily accessible physiotherapy as they do on marketing lucrative rejuvenation lasers, how much more empowered might women feel about aging, about recovering from childbirth, and about trusting their own bodies?
Refocusing on the foundation would completely change the paradigm of women's healthcare for the better.
It truly would. So the next time you hear a pitch for a quick fix for a complex body part, remember the doctor who asks about your bladder when you complain about your vagina. Sometimes, looking at the seemingly unrelated foundation is the only way to save the house.